So I'm Patrick Serruys from the Erasmus University and the Imperial College in London, and we have today an interview with Bernard Chevalier from Paris Sud, Corrado Tamburino from University of Catania, and Renu Virmani, anatomopathologist for CVPAT. And TCT Asia has selected a certain number of slides which maybe will help us to start the debate somewhere. And I think the first question is, do we have a lot of data on BVS? I mean, when I mean data, solid data, which can serve as a guideline in recommendation. Renu, Corrado.
I don't think so. I think we don't have enough data. And I think, although it's promising, but I think we need much more data to feel comfortable, especially in complex cases, because we are beginning to see stent thrombosis, we're seeing aneurysms. So therefore, for me, for simple cases, I have less of a problem. I have more of a problem in complex cases as to whether this technology, that we have enough data for complex cases.
So did we start to do this randomized trial too late? Is that your impression? Because the technology was already there in 2006, and the first result of randomized trial was 2014. Is there a strategy which was not completely correct? What is your impression, Bernard and Corrado?
There is a wide use of this technology in the real world. So we are using by our own experience, but as Dr. Virmani said, we need a randomized study, especially in complex lesions. And the problem that fortunately is not a real problem, because the scaffold has been demonstrated being safe and effective, but there is still some problem in terms of scaffold thrombosis and aneurysms, is that all the investigators and the operators are using as in place of drug-eluting stents.
So from the listing there at the bottom of the slide, stent thrombose, complex lesion, you can read by yourself. What is the worst?
The worst could be the calcific lesions, I think. And the concern, the concern is the scaffold thrombosis. Scaffold thrombosis, because scaffold thrombosis probably is related to the lack of information in how to deploy, correctly deploy, implant the scaffold in the coronary arteries.
Bernard, you agree? You have been there between the scaffold thrombose and the good news for angina pectoris. So what is the most important for you?
Oh, I fully agree. I think stent thrombosis is clearly the main issue we have to consider, and we need to know if we have something different in terms of risk compared to the last generation metallic DES. You asked the question, was it too late to organize this randomized trial? I don't know if it was too late or if our adoption of the device was too quick.
That's it.
It's another question. But clearly there is some discrepancy between the worldwide usage of the device and the relatively late presentation of randomized data.
Among the concern and the perspective, I see DAPT duration. Any idea of what we should do with the DAPT duration, BVS? It seems to me a big question mark.
Yeah, there is no idea. So this is sure that we should give for a long term the DAPT, at least 1 year. We were dealing with Dr. Virmani yesterday. She says more than 1 year, and I agree, fully agree that even 2 years could be reasonable giving a dual antiplatelet therapy. Some investigators suggest a stronger antiplatelet agents instead of the classic clopidogrel, but in many countries it's impossible to give a potent
because I saw that in GHOST, out of the 23 or 26, I mean, only one was ticagrelor and all the rest
most of the
was
patient
clopidogrel.
Yeah.
So it's maybe indication. Let's look what is the next slide. The next slide is very strange. It is unmet need of current stent. And there is neoarteriosclerosis, acute MI, diabetes, CAD progression, and diffuse multivessel disease. I fully agree there are unmet needs in the field, but Renu, do you see any potential improvement in neoatherosclerosis?
Because it degrades so late, at least this one, BVS, for example, the absorb. The question is, are there others on the market which will degrade much faster? And will they be better? And they may prevent neoatherosclerosis. If they degrade like 3 years, we know within 15 months we get neoatherosclerosis. So the question really will be, is it going to prevent? I'd be very surprised. I don't think it's going to prevent neoatherosclerosis because remember, these are thick struts. The endothelialization doesn't take place. It's like going to cipher days, according to me. For the first 2 years, we're going back to cipher.
The so-called story of cyclic strain, shear stress, pulsatility, is that going to play a favorable role? Is that one of the reasons why we have neoatherosclerosis in the cage vessel?
I mean, I think, of course, one of the role is from the cage, but as long as you have struts which protrude into the lumen, no matter what you will do, you will always have shear stress, which is going to be in the negative for us. It's not going to work for us. So therefore, I think we will continue to have. If we had, just like in metal stents, in a way, we have much less shear stress. But there, I think we get much more incompetent endothelium because it never gets covered properly.
Right.
So the question here is, the same thing is going to happen.
And for you, 1 year to have the strut cover and embedded is not enough.
I doubt that it will get embedded. I am a little concerned, especially in complex lesions, AMI lesions. I don't think in ACS patients you'll get that easily coverage. Because remember, there are not enough cells around.
Corrado, acute MI.
Acute
What will be the contribution of BRS in acute MI?
It's a big deal because you know that in acute MI the most difficult part is the vascular caliber assessment because there is some vasoconstriction, there is an acute inflammation, there is a biological burden during this syndrome. And I think that some data are existing. If there is a proper vascular sizing, you can implant a scaffold in the coronary artery. So what I suggest is that if you want to use the scaffold in acute MI, you should use intravascular imaging before implanting the scaffold with a good dosage of nitroglycerin for achieving a good dilatation. But there is some report showing a slow increase in scaffold thrombosis, some others showing normal behavior of the scaffold as in DS.
A difficult one for you, Bernard, diabetes. Any expectation there?
I think it's a really a difficult question. I fully agree. We have not so much data regarding diabetes. We have some propensity matching with absorb extend compared to data from Xiant from Spirit trials, showing good trend. But I think it's clearly something we need more data. There is no specific trial focused on this type of patient. So clearly the question is still open.
The CAD progression, I'll take it because it's my hobby. I think that we have to do much more. I mean, we're still acting as a plumber, putting the stand and then forgetting the statin. I mean, you will have the statin and the PCSK9. I mean, there will be probably a way to interfere with the disease in a profound way, but that will be the responsibility of the interventional cardiologist, and also maybe long-term monotherapy with antiplatelet or dual antiplatelet therapy will have a role. What can we do about the multiple vessel disease? I'll go back to Corrado.
Multiple vessel disease is an interesting point because when you have no indication to surgery, so this is the point as such, in this case showed in the slide, and you have to reconstruct the arteries, it should be preferred having something that disappears in order to leave the coronary artery even after 3 years, so too late probably, the artery free from any foreign body. Because the metallic burden in such coronary artery tree should be too heavy to be tolerated by the patient, because 20 centimeters of stents is a big number, by the way.
Right. I think one thing at least we can say is that if you put metal, the only future is a reduction of the lumen. Something will grow inside the cage. If you give a biodegradable scaffold, there is the possibility of remodeling and maybe some late lumen enlargement in some case. So I think that that's the only hope that we have. What is the next
I
slide?
want to say one thing. We're not thinking innovatively. I think when you have multi-vessel, such complex disease as you're seeing small vessel disease. Stents really don't work. Even when you think of 2.5 in BVS, I think it's too bulky for a 2.5 vessel. So for me, the question is, should you do something like drug-coated balloon in the distal and proximally you put in stents? You'll have to become innovative. You cannot do one thing fits all.
But it's what we usually do. So we prepare the lesion, the strong and heavy preparation, and then we act consequently. So if there is a small vessel, we use drug-eluting balloon, which in small vessel behaves very well, have a good performance, and in larger vessel we implant the scaffold. In very large vessels, such as left main, we implant the ES. So a combined, a mix, hybrid, percutaneous procedure is the best choice in such cases.
So there is a slide there with a 7 bullets. I think in general I will agree with the 3 first bullets, but I think that the last 4, there is discussion. I think that we don't know how to handle the DAPT in this technology. I think we will see a late event. I mean, there have been a report in the European Heart Journal of late stent thrombose, scaffold thrombose in a patient stopping aspirin and DAPT. So vessel-free for future intervention, I have not yet seen that. That seems a little bit far-fetched. I mean, almost marketing.
It's hypothetical. It's hypothetical because
Yeah.
if you are able implanting a scaffold or a stent in the future,
Yeah.
you can reimplant a scaffold or a stent.
But I'm unaware of a single case of that, so after 8 years. Let's see what is the next slide. That is a slide showing on one hand the extent registry of Absorb, which is in blue, and then the science making a compilation of Spirit 1, 2, and 3. I will be the first to talk about that. That slide seems to me very, very optimistic. I mean, it looks almost like bare metal stent versus drug-eluting stent. Well, what is your guess? It is, of course, almost 4 years, but that early separation, I don't think that I have seen that. If there is a separation, I guess it will come around year 3 or 4. What do you think, Bernard?
Yes, I fully agree. You can think that the angiographic follow-up of the Spirit 1, 2, and 3 trials, particularly Spirit 2 trial and Spirit 1, can induce more TLR in the Spirit trial excisions compared to Absorb Extend, which is only a registry with no angiographic follow-up. So that could explain the difference we see at 180 days. Clearly, this is a limitation of this kind of approach of one-city matching, and nothing is better than randomized trial to evaluate a potential difference.
Let's say that we have to wait for the randomized trial, and that's it.
I think this is very bad for science, which is absolutely not true. If you look at 4 or 5 years out, you're saying that there's 14% None of the trials
Yeah.
showed us that. So for me, it's very hard to
Yeah.
relate with this.
Yeah, we have always bath mouth for the previous generation.
Yes.
We did a retrospective analysis, a comparison matching population for the Ghost EU with all the science data. And so we analyzed 950 pairs. And the clinical outcome is exactly the same. So it's below 10%. So it's not 40%.
that I would believe.
Yeah.
I totally
Disease.
agree.
Yeah.
Below 10%.
It's below 10%.
Okay, let's see what we have after that. We have the first randomized trial. I have to tell you that the primary endpoint is, as a matter of fact, at 3 years, at 36 months. But of course, the world and the medical community was waiting for some randomized data. So we took the difficult decision with the steering committee and the DCMB to show the data at 1 year. And of course, it's not power for clinical data, so it has not too much information. But we may say that in both groups, the number were quite low, sometimes below 5%, which is quite reassuring. But we will see if these gradient between the metallic and the BRS appear at a certain point, and at what time it will appear. Scaffold thrombose in that trial was, like we see in many clinical series, acute and subacute. And then I think is the fact that these bulky, high struts interfere with the shear stress, activate the platelet. You have at that side an endothelium which is destroyed, so you have nothing to counteract that activation of the platelet, and this is really the weak point. And I think that two things has to be done: reduce the thickness of the struts. Some of them have already started to do that, and probably go to an antiplatelet agent, which is more potent, type ticagrelor, and we will see in that there will be certainly a lot of trial to try to prove the point.
But
Yeah?
I have another suggestion. I think we have to reduce the polymer burden.
Yeah.
Remember, if you look at stent to ordinary drug-eluting stents and you look at the artery, the ratio is like only 12% of the vessel wall is covered by the stent.
Yeah, and now
Here it's 30%.
26,
30 something.
26, yeah.
It's double, if not more.
And polymer absorption causes
Yeah.
inflammation in the acute phase also.
Absolutely. So I think there are things we can do to improve.
I think this afternoon we have a debate. I mean, can we expect more from the biodegradable? I mean, there are a few tricks to make it strong and thin, but we will have to work very hard to find a solution without creating a new problem. Let's see what is the next slide. The next slide, I'll let that slide to Bernard, which has presented the topic, I think, at the ACS and in many occasions. I'll let you talk, and then I'll give you my feeling about these findings.
Yes, the slide is showing a difference in terms of site diagnosed reported angina using the adverse event form of the CRF. And you can see that cumulative rate of angina at 1 year is 16.4 for the absorb and 25.6 for the Xians. We have to consider two things. We have two types of data about angina in the absorb 2. The first one, which was pre-specified on specific endpoint, is Seattle Angina Questionnaire, and there is no difference for 6 months from 12 months evaluation with absorb versus Xians. And we have this data, which is a post-hoc analysis, not pre-specified. We can explain maybe partly the discrepancy between these two types of data by the fact that Seattle is evaluating a window of 4 weeks, so window 4 weeks at 6 months, window 4 weeks at 12 months, and it's not evaluating what happens between these windows. But we have also to consider the methodology which is used for this reporting. It's based on the site reporting, analyzing the complaint of the patient. You can think that maybe we have under-reporting or over-reporting. The trial was supposed to be single-blinded, but we know that some patients are no longer blinded. And we know also that the site personnel is not blinded. And this event have not been adjudicated by the CEC, by the Clinical Event Committee. So that means that we have a lot of limitation in the reporting of this angina. So we have to take that with a lot of caution.
I think it's an excellent answer. I think that just to paraphrase, I went through all the ECRF of this trial because I was quite skeptical. And it's true that the angina reported by the site is most of the time a free text. And obviously the medical staff already summarized these free texts, and very quickly chest pain became angina, equivalent angina has nothing to do with the medical equivalent angina. So that was the reading all these CRF, I realized that you need a methodology which is asking very specific question. And even the SAQ, in the first line, they only mention chest pain and tightness of the chest. So there is nothing about irradiation to the jaw of the internal arm, side of the arm, and so. That's the first level. After that, of course, there is some regroupment of these clinical syndrome. I think we could have a lot of surprise when it will be done very strictly. The advantage of the SAQ is the questions are extremely well done. The description of angina is not perfect, but what is not very good from my point of view is that we don't do the SAQ at the time of an event. So basically, it's done on a regular time, and if the patient had a prior PCI but is perfectly well, the first sentence of the questionnaire is over the last 4 weeks. No, over the last 4 weeks, I'm fine. So I'm responding fine, and I underestimate the fact that I had a prior PCI. So I think it's very important because it's clear that we end up in every trial with a 25% of angina pectoris, either because we don't do properly the diagnose, we don't dilate the right lesion, there is a problem of microvasculature. So I can understand that the result will never be 100%. But I think there will be a change in the way to analyze the trial in the future. We cannot stay in the 5-6% of event, TLR, TVR, death, etc. Patients are going on the table not to have a TLR or a non-TLR, but to have a reduction of their angina. So that's maybe the good things of that first analysis of angina in Absorb 2. Let's see what we have. AVRBO, I think we can go very fast, but in the sense it's a small trial, somewhat underpowered, but I think that Corrado, Bernard, you will agree that ES, BES, or BVS seems to be quite comparable, which is good news, which means that at least this biodegradable stent can support the comparison with the metal. I'm looking at the time. I think we still have 5 minutes. Here is the American trial, and I'll give the floor to Renu because these trials are quite complex, and I think, for instance, Absorb 4 as a primary endpoint angina claim, and that if it is not there, will be a major, major issue. Could you comment on these two trials, Renu?
I think it's a very important trial, the Absorb 3. To me, that's the more important than even Absorb 4. Really, if this does not show equivalency, the whole thing will fall apart, and I think it will show equivalency. I'd be surprised if it didn't. Because remember, we only took not very complex cases. We had single vessel or two vessel disease, and you were allowed to put in 2 stents. So for me, that's okay. I think
Right.
it'll behave very well in those circumstances, provided it is put in properly. I think that's the trick, is that putting a stent in is not like DES. This is harder to put it in. And we'll have people taken care of it.
I have a question for all of you. Let's say that the Absorb 3 reach is non-inferiority.
Yes.
Okay? But we have a ratio scaffold thrombose 2-to-1. How is the community going to react? They will say, we'll work and concentrate to fix that problem, or it will be
Depends how long
a
is
setback.
Absorb 3 follow-up. I don't remember the duration of the
It's a
follow-up.
1 year.
It's a one-year
1 year
trial,
is
but
too early for assessing the vasomotion.
but
of
I
the
mean,
lumen.
what they are doing very smart is that they
Subgroup.
have a 1-year follow-up, and then it's a kind of landmark study, and then they
Certain
look to
groups.
the long-term follow-up, and they merge that with the Absorb 4. So you don't believe that a difference in scaffold thrombose could slow down the adoption, even if there is a non-inferiority globally?
I think that we are focusing on scaffold thrombosis. We have to focus on the survival at 1 year or 2 years,
Right.
which is the same.
Yeah.
So scaffold thrombosis is one
It's a
undesired effect, but the
mechanistic
other,
incident.
yeah. So there are undesired effects and deaths or thrombosis and thrombosis. So if we have more thrombosis in the scaffold group, but we have the same death, means that there is something else in the other arm. So I wouldn't be so scared.
Absolutely.
Caution, obviously, and taking care and solving the problem of scaffold thrombosis. So taking all the...
I think the community won't tolerate it.
Yeah.
I am
I fully
afraid the
agree.
community will not tolerate, because you've been spoiled with DES.
Yeah, absolutely.
DES has second generation have very good results. You can't go back to cipher
no.
days. This is what was happening here.
No, I
It-
fully agree. I think it will be a limitation for adoption if we have more scaffold thrombosis.
It's a very important, almost historical moment, because you remember the story was initially with Absorb Extend, which was done in many countries in the world, emerged a little bit the story of angina pectoris, etc., etc. Some of the countries were eliminated of these analyses. Then there is a kind of hype in angina up to the point that you end up with a big trial where suddenly the primary endpoint is going to be angina, which is in itself a very good thing. We are a doctor to treat angina and not to quantify the deficiency of the device. But I'm curious to see if that period is going to be change in the type of the way you are going to do the trial in the future. It may be. That will be the interesting part, but I have first to see if there is an effect on angina, because so far all the mechanistic interpretation that we have provide, none of them has been proved, and they are all very theoretical, either working for the early time or the late time, but not covering the entire things. It's maybe a little bit pessimistic note, but we are not pessimistic, we are realistic, yeah? Thank you
but-
very much.
You're very right. Thank you. And I think you ended very well. I have
Thank
to
you very
congratulate
much.
you.
Thank you very much.
Thank you.
Thank you.
Thank you.